Okay, well, welcome to Pediatric Grand Rounds. I'm pleased to hand this over to Dr. Mel Hyman, who will introduce our speaker for today.
Hi, everybody. It's my pleasure to introduce Dr. Adjoa Eniani Yaboa, who is currently an instructor in medicine at Harvard Medical School and a gastroenterologist at Mass General Hospital. She received her medical degree from the University of Cincinnati, completed her internal medicine residency and chief residency at the University of Illinois in Chicago, and completed a gastroenterology fellowship at the University of Chicago, where she also served as a chief resident during her training. After completing her GI training, she completed the Commonwealth Fund Fellowship in Minority Health Policy through Harvard Medical School, where she also received her MPH, Master's in Public Health, with a focus on health policy from the Harvard T.H. Chan School of Public Health. She's passionate about health equity and GI disorders, particularly colorectal cancer screening and inflammatory bowel disease in minority communities. Her goal is to advance care, improve access, and eliminate disparities in vulnerable patient populations. She believes that every human should have the best opportunity to achieve the best health possible, and that we need to dismantle the barriers that result in inequities. And with that, I'm going to turn it over to Dr. Eniani Yaboa to share your screen and provide us with your discussion about GI disparities in pediatric gastroenterology, the road to equity. Thank you.
Thank you so much. Thank you so much for that introduction. Thank you all for being here. I'm super honored to speak with you today about a topic that's near and dear to my heart. I really appreciate the invitation. The title of my talk is Understanding Health Disparities in Pediatric Gastroenterology and the Road to Equity. All right, so the goals and objectives of this talk are to understand the social determinants of health and how they lead to health disparities, understand health disparities in pediatric gastrointestinal disorders, and then define strategies to address inequities in GI. So in order to understand health disparities, we need to understand the social determinants of health. So I'm going to start with a question. So what are health disparities and why do they exist? So I would argue that disparities in health are due to long-standing social inequities that are built into America's policies that have placed certain populations and certain communities at a baseline of disadvantage. So again, to understand health disparities, we need to understand what the term the social determinants of health means. So this is a definition from the World Health Organization, and these are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. These forces and systems include economic policies and systems, development agendas, social norms, social policies, and political systems. So as an example, take the policy of redlining. So the federal government, through the Federal Housing Administration, used color codes to identify areas that were off limits for providing mortgage loans predominantly to Black people. So this has contributed to the same neighborhood segregation that we see today. So these same neighborhoods now have poor funding and upkeep from local and national governments. They might have poorly funded schools with limited economic opportunity and low-wage jobs, and possibly less access to employer provided insurance. They might be in a food desert. They might be in densely populated areas. They might have poor quality housing, all of these factors which lead to poor health outcomes. So this is a little bit more about the social determinants of health and some of the separate categories of the social determinants. So we think about, for instance, economic stability and whether people have access to gainful employment, whether they have opportunities to make a living wage. We think about the neighborhood and physical environment. Do people have access to quality housing and transportation? Do they feel safe in their neighborhood? Is it walkable? Is there green space? We think about education and early childhood educational opportunities and higher educational opportunities. We also think about food and whether they have access to healthy food options or if they live in a food desert. And then the community and social context, are there support systems? Is there community engagement? Do people feel disproportionate share of discrimination and stress? And then we also think about the healthcare system. Do individuals have access to coverage? Do they have access to providers? And do they have access to providers that speak their language? All of these factors can lead to disproportionate share of mortality, morbidity, life expectancy, diminished life expectancy, a lot of healthcare costs, poor health status, all of which lead to downstream disparities. So this is from one of my friends and colleagues and mentors, Dr. Dale Gray. He's an adult gastroenterologist as well, looking at how the upstream determinants impact these midstream determinants that lead to downstream health outcomes. So if we think about our upstream policies, social inequities, racism, ethnicity, gender, zip code, these upstream factors that then impact these midstream factors like unemployment, or if you have access to employment, whether you live in unsafe or overcrowded housing, whether you have income instability, if you have food insecurity and poor diet, or if you have a disproportionate exposure to toxins. And then all of these factors can lead to these downstream health outcomes like heart disease, asthma, obesity and overweight, type 2 diabetes, cancer, and really a whole host of different diseases. This same graphic can be made almost for any disease out there where we see disparities. This was actually initially developed to show how the upstream determinants of health lead to poor health outcomes in COVID-19, but these same things can be used to illustrate how disparities develop in a whole host of different disease states. So if we think about some of the baseline barriers to care for minority communities, thinking about uninsured rates among non-elderly individuals by race and ethnicity in 2018, we see that the highest number in American Indian Alaska Natives, then Hispanic individuals, and then Black individuals. Again, looking at baseline barriers and access to care and those who are have disproportionate share of poverty or income below the poverty limit. You can again see highest number in American Indian Alaska Natives, Black individuals, and Hispanic individuals. So the same communities are hit over and over, time and time again. Now I want to shift here for one moment and talk about racism as a public health crisis. So this year has really pulled the curtain on racism in America. The killings of multiple unarmed Black people at the hands of police, many of whom have yet to receive justice, compounded with the disproportionate number of COVID-19 cases and deaths in minority communities has shown just how prevalent racism is in our society, and that we cannot ignore racism and inequity anymore. Many states and local governments have put money to address these social determinants of health that lead to health disparities. And labeling it as a public health crisis to me is almost like a rally cry. It means all hands on deck. Not all hands on deck, all hands on deck. Racism isn't the problem of some of us, it's really the problem of all of us. And we all need to get together and work together if we're going to dismantle racism in our society. And I really, really love this quote because it really kind of illustrates, address how we think about addressing racism, and that not everything that is faced can be changed, but nothing can be changed until it's faced. Until we face racism in our society, we cannot dismantle it. So we all need to face it, name it, and work together to dismantle it. So let's talk a little bit more about racism and racism as a social determinant of health. So what is racism? So it's a system of structuring opportunity and assigning value based on how one looks or their race, which is a social construct. It unfairly disadvantages some individuals and unfairly advantages other individuals. Now, thinking about the different levels of racism, so this is from a leading scholar in the study of racism and the impact on health and health outcomes, Dr. Kamara Jones. And she actually has this allegory called A Gardener's Tale, where she describes a gardener and the gardener's preference for certain flowers over others and how it impacts the development of the flowers over time. And she compares this to racism in our society. And I would really suggest that anybody who has never experienced racism really go and check out her TED Talk. You can just Google it and you can find it, because it really makes racism easier to understand for those particularly who have not experienced it firsthand. But she describes 3 different levels of racism. So she first starts with institutionalized racism, which is differential access to the goods, services, and opportunities of society by race. Institutionalized racism is normative, sometimes it's legalized, and it often manifests as inherited disadvantage. So it manifests as difference in access to material conditions like quality education and housing, medical facilities, having a safe and clean environment, but it also manifests as differential access to power, like access to resources, access to leadership opportunities, access to wealth and voting rights, and really access to the table and having a seat and a voice at the table. And it's really important to note that institutionalized racism is all over our society. It lies underneath and all around and across our society. It's built into our history and our culture and our values and our policies. And in order to dismantle it, we need to understand that it is everywhere. And then we think about also personalized racism as the next level. And this is really racism between individuals. And this is what people commonly think about when they hear the word racism. So this is, an example of this could be police violence or using racial slurs against other communities. All of that is considered personalized racism. And then there's internalized racism, which to me is the saddest form. So this is acceptance by members of the stigmatized races of negative messages about their own abilities and intrinsic worth. So an example of this is a Black patient wanting to see only white providers because they think Black providers aren't as smart as white providers. So again, I would really suggest that all of you go and check out Dr. Kamara Jones' TED Talk. If you Google Kamara Jones' TED Talk, you can see, you can hear her allegories on race, and she's really a phenomenal speaker, and it really helps to put all of this into perspective. Now, what about the impact of racism on health? So discrimination leads to a stress response with emotional, physiologic, and behavioral changes. It also leads to hypervigilance, which is increased awareness and anticipation of protecting oneself against additional trauma. We also see hypervigilance in PTSD as well. So acute stress is adaptive, but chronic stress can have negative impacts on health. So we've seen chronic stress in relation to hypertension-related disparities, increased risk of mortality amongst older adults, low birth weight and preterm birth, and smoking and tobacco usage as well. It's also important to note that police violence negatively impacts mental and physical health. So Black and American Indian men and women are significantly more likely to die at the hands of police. So experiencing police brutality, witnessing it on TV, hearing stories from friends and family members, worrying that it could be you or a family member really are significant stressors that can negatively impact mental and physical health and lead to poor health outcomes. Again, this is from Dr. Kamara Jones, looking at the impacts of racism on health and the 3 levels of racism and how they interact to lead to poor health outcomes. So there's internalized racism, which can impact your health behaviors. There's institutionalized racism, which can impact your socioeconomic status and access to healthcare and the other social determinants of health. And then there's personally mediated racism, which can lead to chronic stress. It can also lead to differential treatment by providers, which can all lead to poor health outcomes down the line. Now I'm going to shift for a moment and talk about implicit bias in healthcare professionals. So it's important to note that physicians and nurses exhibit implicit bias to the same degree as the general public. And that makes sense, right? Because we're all human. But it's important to note that implicit bias really can have a negative impact on patients. So pro-white anti-Black physician bias is associated with white patients feeling more respected by their physician. Black patients felt less respected. They had lower levels of liking their providers. They had less willingness to recommend their provider to someone else. And they felt overall that their visits were less collaborative. Physician bias was associated with verbal dominance by the physician with Black patients. And pro-white physician bias was associated with Black patients being less likely to fill their medications. I think the one silver lining, especially for you all, is that pediatricians overall held less implicit bias than other MDs. But I would recommend that everybody here, if you haven't before, take the implicit association test so you know what biases that you bring into patient encounters, into grant review committees, into trainee selection committees, and really into the general public, just so you know kind of what you're carrying with you. So then if you're in these situations, you can actively work to counteract any bias that you have. And it's available, it's easily accessible and free as well. It's Project Implicit. All right, now let's shift and talk about health disparities in gastroenterology. We're going to first start with disparities in workup. So this is a study that I did with colleagues at the University of Chicago, looking at patients who came in on 2 separate occasions with diagnoses of iron deficiency, anemia, and diarrhea. They came in with those 2 diagnoses at 2 separate encounters spaced more than 6 months apart. So with this, we saw that Black patients had a 90.5% decreased odds of receiving a workup for iron deficiency, anemia, and diarrhea. And then also publicly insured patients had a 90% decreased odds of having the appropriate workup when coming in with these symptoms. And we considered an appropriate workup to be an upper endoscopy with biopsies, ileocolonoscopy, so colonoscopy getting into the ileum, and celiac serologies. In this same study, we saw that time to colonoscopy was significantly longer in those who were publicly insured compared to those who were privately insured. So that study showed that individuals who come in with symptoms suggestive of IBD or celiac disease, so iron deficiency, anemia, and diarrhea, are less likely to be worked up for these diseases if they are Black or publicly insured. So I've actually presented that study before at a conference, and the most common comment that I received from other people who came up to see my poster were that, well, that totally makes sense because Black people don't get celiac disease, so it makes sense that people aren't looking at it. Well, let's unpack that. So now let's look at the prevalence of celiac disease by race and ethnicity. So this is a study from Haynes of 14,700 patients who were checked for tissue transglutaminase and endomysial antibodies, which we see in celiac disease. The overall prevalence of celiac disease in this population was 0.79. The prevalence of positive serologies by race, so much higher in non-Hispanic whites, 1.08%, in Mexican individuals, 0.23%, in Black individuals, 0.22%, and then in the other Hispanic population, 0.15%. So yes, the prevalence was highest in the white population, but it was not 0 in other populations. It still suggested that we look for celiac disease in all patients, regardless of their race and ethnicity, and guidelines do not ever say that we should use race as a guideline for whether or not we should look for celiac disease. And it's also important to note that minorities were more likely to have a weakly positive anti-tissue transglutaminase antibody and positive endomysial antibodies than the white population, which suggests that the TTG threshold might be lower in minority populations. Furthermore, we may see less celiac disease in Black patients because we're not looking for it. It might be underdiagnosed. So this was a study looking at Black and white patients who came into a single center for upper endoscopy, and they came in with symptoms of diarrhea, iron deficiency, anemia, and weight loss. All patients were there for endoscopy, but Black patients were less likely to have biopsies of the duodenum for celiac disease when they came in. So Black patients had 28% rate of biopsies and white patient had 48%. So the patients were in the endoscopy lab, they were having a procedure, but Black patients were less likely to have the biopsies because again, providers weren't looking for celiac disease. So more on disparities in celiac disease. So those who have high socioeconomic status, this is associated with better overall health, better celiac disease related health and lower symptom burden. And low socioeconomic status is associated with worse celiac disease related health and more symptoms in comparison to those who are high socioeconomic status. About 50% of pediatric celiac disease patients are lost to follow-up within 3 years of their diagnosis. Of these patients, about more than 75% who are lost within a year are from a low-income group, and then about 50% of children with Medicaid and CHIP are lost to follow-up at 1 year after diagnosis. So kids who are lower income have worse outcomes in celiac disease, and they're more likely to be lost to follow-up as well. All right, now we're going to shift and talk about inflammatory bowel disease. So the incidence of IBD in minority populations. So most of the incidence data that we have on inflammatory bowel disease is based on the Olmsted, Minnesota database, which is about 95% white. There was a study done, it was published in 2014, but it used data from the National Health Interview Survey from 1999. In this population, they found that the incidence of IBD in white patients was 70.2 per 100,000, in Black patients was 24.9 per 100,000, and in Hispanic individuals was 9.9 per 100,000. However, more recent incidence data for minority populations is very limited. All right, so I gave us that information so we can kind of see where we're starting from. Now we can talk about different disparities that we see in IBD. And we're going to start by talking about disparities in access, utilization, cost, and adherence in IBD. So this was a study looking at perceived barriers in access to care for Black and white IBD patients. In this study, they saw that Black IBD patients had a higher percentage of Black IBD patients had worries over their cost of healthcare, and a higher percentage of Black IBD patients had difficulty obtaining referrals to specialists. And these findings were both significant. And then looking at more disparities. So Black IBD patients have more worries over the cost of care and difficulty obtaining referrals, like we talked about. Black IBD patients are less likely to be under the regular care of a gastroenterologist or IBD specialist compared to white IBD patients, and likely as a result of lower likelihood to be under the outpatient care of a gastroenterologist or IBD specialists. Black patients with IBD are almost 2 times as likely to be seen in the emergency department. And Black and Hispanic patients with Crohn's disease have an increased hospital length of stay compared to white patients with Crohn's disease. So we see disparities in access and utilization based on race and ethnicity. When we look at adherence, we see that Black IBD patients have a lower medication adherence compared to white IBD patients. But we've also seen that patients who have more trust in their physician had higher rates of medication adherence. So it's, I think, important to note here that adherence is not only something that we think about for the patient and that we blame the patient, but sometimes it's us as well. Are we instilling trust in our patients? Earlier slide, we saw physician bias was associated with adherence. So I think oftentimes we need to look at ourselves as providers as well, particularly when our patients aren't coming in and taking their medications. And then we also need to think about other factors in the social determinants that impact individuals' access and cost of care as well. All right, so along the same lines, now we're going to talk about food insecurity and IBD. So this was a study assessing food insecurity, lack of social support, and association with healthcare financial toxicity and emergency department utilization. This study used data from the National Health Interview Survey. So in this study, they found that 14% of the US IBD population was food insecure. And they also found that food insecurity was associated with an increased risk of financial hardship on multivariate analysis. About 53% of these IBD patients also reported lack of social support. And in the study, they found that food insecurity and poor social support was associated with difficulty paying medical bills, medical non-adherence due to cost, financial distress, lacking affordable healthcare. So this is a graphic looking at the relationship between food insecurity and the prevalence of financial toxicity measures. So the lighter bars here represent those who are food secure. The medium gray bars represent low food security, and the black bars represent very low food security. So you can see here that those who have financial hardships from medical bills, those with the highest percentage of financial hardship were those with low food security and very low food security. When we looked at overall financial distress, similarly, those who have low food security and very low food security had the highest prevalence of financial distress. I mean, it's a similar theme as we go across. Those with cost-related medication non-adherence, again, those with low food security and very low food security had the highest prevalence. And healthcare unaffordability. Again, those with low food security and very low food security had the highest prevalence. So it's really important to talk with our patients about cost of healthcare, difficulty accessing care, and difficulty affording care, because it really impacts their treatment and their outcomes. And they might not always volunteer this information to us unless we ask. All right, disparities in disease severity and outcomes. So this is a study from the Improved Care Now network looking at patients at pediatric Crohn's disease patients at diagnosis and at 1 year, and looking at racial differences in disease severity. So here the black bars represent black patients and the gray bars represent white patients. So here, black patients at diagnosis had lower rates of remission compared to white pediatric Crohn's disease patients. At diagnosis, again, black patients had lower rates of mild disease and higher percentage of moderate to severe disease. And similarly, at 1 year, black patients with Crohn's, pediatric patients who were black with Crohn's disease had lower rates of remission and a higher percentage of moderate to severe disease in comparison to white pediatric IBD Crohn's disease patients. And now let's shift and talk about social determinants of health and IBD outcomes. So this was a study out of Canada looking at low socioeconomic status and relationship or risk of adverse outcomes in IBD. I think it's important to note here that in Canada, they have universal health care, so everybody should have access to coverage. So in this study, low socioeconomic status was associated with more ICU stays, more hospitalizations, higher mortality risk, higher risk of severe disease, higher corticosteroid usage, and increased annual outpatient visits. Again, this suggests that we should really be addressing socioeconomic factors with our IBD patients at diagnosis and throughout the disease course, and really not just our IBD patients, but all of our patients. We should always talk about socioeconomic factors with our patients, because we know that this can lead to poor outcomes down the line. And not only should we ask, but we should have a way to connect patients to resources as well. All right, now let's talk about disparities in surgery and surgical outcomes. So this is a table from a systematic review from looking at 198 countries, 198 papers from 6 countries, excuse me, looking at rates, racial disparities in rates of surgery in Crohn's and ulcerative colitis patients. So in this study, they saw that the highest rates for Crohn's disease surgery were in the Hispanic population, followed by the Black population. And then at 1 year and 5 years, highest rates in the Black population, although they did not have the numbers for the Hispanic population. And then when they looked at ulcerative colitis, the highest rates were in the Hispanic population. And then the highest rates at 1 year and 5 years, again, were in the Hispanic population. So there are racial disparities in the rates of surgery for Crohn's disease and ulcerative colitis as well. So more on disparities in surgery for IBD patients. So Black patients with Crohn's disease are more likely to have penetrating and stricturing disease, which can be a more severe disease phenotype, and they're more likely to have surgery than white patients. Black patients have about 20% increased odds of major surgical complications, even after adjustment for sex and preoperative conditions, comorbidities, lifestyle factors, and ASA class. Black patients with IBD have increased rates of death and serious morbidity after surgery compared to white patients. Again, it's similar theme. Black patients have higher rates of renal insufficiency, bleeding requiring transfusion, and sepsis after IBD surgery compared to white patients. And then Hispanic and Black patients have more readmissions after IBD surgery compared to white patients. And there's lower rates of clinical remission in Black patients in comparison to white patients after IBD surgery. So there are significant disparities in surgical complications by race and ethnicity. All right, now we're going to shift and talk about liver disease, just making sure I'm on time. All right, so this is a similar graphic to what we saw earlier, looking at how the upstream determinants lead to these midstream determinants that lead to downstream liver health outcomes. Again, this same graphic can be done probably in most diseases that we see disparities, which is most diseases out there, unfortunately. But here you can see how the upstream determinants of health, like systemic social policies and laws, our societal structure, the community environment and resources, and racism and implicit bias lead to these midstream determinants like material conditions or housing stability or instability, food security and income stability, psychosocial factors like access to social support, which we know is important for liver transplant particularly, behavioral factors like alcohol use, illicit drug use, and exercise habits, which can put people at risk for liver disease. And then healthcare access, like access to high quality care, having access to coverage, and health literacy. All of these factors lead to downstream liver health outcomes like increased risk of liver disease, increased risk of chronic liver disease, complications, and poor symptom control. And I would also add here likelihood of liver transplantation as well. All right, so looking at disparities in pediatric liver disease. So there are racial and ethnic disparities in pediatric liver disease hospitalizations. We know that Black patients make up about 50% of pediatric liver disease hospitalizations by race. When we look by ethnicity, Hispanic individuals make up about 50% of pediatric liver disease hospitalizations. And then Medicaid patients make up about 54.6% of admissions. Children with liver disease from underserved counties have higher death rates overall in comparison to those from high income counties, so about 30% higher. And those from underserved counties are also less likely to be listed for transplant. So they're about 27% less likely. And then children in areas of high neighborhood socioeconomic deprivation have decreased graft survival and overall survival. So interestingly, for each 0.1 increase in neighborhood deprivation, you see an associated 11.5% increased risk of graft failure. So this really does show that these neighborhood factors really have an important influence on health outcomes. So disparities in pediatric and young adult liver transplantation. So Black patients tend to be transplanted at younger ages and have higher MELD at transplant. So they're transplanted younger and they're sicker when they get to transplant. Black individuals and other minorities have lower graft survival and overall survival compared to white patients. So the 10-year graft survival is 84% for Black pediatric patients and only 60% for Black. For 84% for white pediatric liver disease patients and only 60% for Black patients. And the 10-year patient survival, so the 10-year overall survival is about 92% for white patients and then significantly lower at 65% for Black patients. And then the rate of graft failure and mortality is much higher for Black patients and other minorities than for white patients, and even after adjustment for multiple factors. And then when we look at the distribution of some of these neighborhood factors by race and ethnicity, in this study, we saw that Black patients had lower socioeconomic status, more poverty, lower levels of parental education, more public assistance usage, lower income, more female-headed households, more male unemployment, and higher levels of neighborhood deprivation. So again, all of these social determinants that lead to downstream health outcomes, and probably also what led to some of these poor health outcomes that we're seeing in this study as well. All right, so let's talk about the road to equity in gastroenterology. So far, everything we've talked about has been pretty grim and depressing, but now for this phase of the talk, we can really focus in on and hone in on what can be done to really level the playing field in gastroenterology. So the first step is diversifying the workforce. So we know that individuals from underrepresented groups are more likely to do disparities research and work in areas where they can take care of diverse patient populations. Unfortunately, the GI workforce does not reflect the diversity that we see in the US population. So only about 10% of active GI physicians are from underrepresented groups, about 4% are Black, 6% are Hispanic, and actually 0, and I think the exact number is at 0.2% are American Indian Alaska Native. So we're really lagging behind in diversifying the workforce. And we know that diversifying the workforce does have an impact on health disparities. And I think it's important here now to shift and talk about the leaky pipeline. So we're talking about diversifying the workforce and thinking about how diverse the US population is, but there's a significant drop off when we look at medical school. So it's about, I think it's the most recent numbers said 33%, but 33 to 46%, and we see a drop off to about 11%, and then even further drop off, at least in internal medicine, to about 9%, and then even more so to GI. So I think it's really important to focus here on this, medical school stage, and really thinking about how are we going to get more underrepresented minorities into medical school. And I think we need to look at it from both sides. So we need to work on mentorship, sponsorship, really getting people in the door, mentoring high school students, mentoring undergraduate students. But then if we're going to ask more people to apply, we really also need to look internally and look at our own processes for evaluating applications, right? And making sure that we're doing things equitably and fairly, and really thinking about how some of these social factors can impact things, and really looking closely at our own policies when we do medical school admissions, to make sure that, yes, we're recruiting more people in, but we're also doing things fairly from the other end as well. Again, looking at racial differences in medical school matriculants, you can see here that there are significantly higher rates of white female and white male matriculants in comparison to Black female and Black male matriculants. So we really need to work on this leaky pipeline and get more underrepresented minorities into medical school. So how should we diversify the workforce? So I talked about it a little bit already. We need mentorship and sponsorship. So mentorship, and it can be done at all levels, from senior faculty to residents, medical students. You can always mentor the people who came before you. So I have mentored at every stage of my career, and I continue to mentor. And it's really important to mentor people who don't look like you, so that we can really work on diversifying the workforce. Sponsorship is also very important. It's been very important for my career as well. And that's when people put your name out there for opportunities and advancement when you're not in the room. So really people putting you forward for success even when you're not around. We need equitable promotions processes. We know that underrepresented minorities are more likely to work on diversity committees and do DEI work. And oftentimes this work is not promotable, so we need to look and see and evaluate why we value some work over others, and also who are we asking to do that work. It's really important to go and evaluate our promotions processes. We need an inclusive work environment. So one of my mentors previously at the University of Chicago, she looked at diversity and inclusion like a party. So diversity thinks about who are we inviting to the party, right? But inclusion is really about, like, an example of that is, are we asking these people to dance? So inclusion is important. So people who are from underrepresented groups really feel welcome and valued, and really feel like they have a voice, a seat and a voice at the table. It's really, really important, not just to focus on diversity, but really focus on inclusion, and also focus on retention as well. So not only bringing people in the door, making sure that they feel included, and making sure that they continue to progress as they should. We also need equitable pay, ongoing implicit bias and anti-racism efforts, and diverse leadership. I think diversifying leadership is really important because those who are coming before, or after, rather, trainees, students, they see people in positions of leadership that look like them. And they realize that these fields are for them, and maybe these positions of leadership are for them as well. So representation really does matter. And it's really important to work on diversifying not only the field of medicine, but leadership in medicine as well. So addressing health disparities in GI, and really not just GI, but in general, it takes a multi-level approach, and it takes an approach from the provider, organization, community, and policy levels. So we've talked about this a little bit already, but at the provider level, we really need to look internally. We need to address implicit bias and work on actively becoming anti-racist. So really think about, that implicit association test, and thinking about the biases that you bring into each encounter, whether it's with a patient, whether it's grant review, whether it's trainee and student selection committees. And then at the GI practice or healthcare organization level, we need anti-racism training for all staff. Every single person who comes in contact with a patient should have this training, not just providers. And then we need equity and access for all patient populations. So if we look around and we realize that we're taking care of certain populations more than other populations, and there are other groups that we're not seeing in our clinics and not seeing have access to regular care, we need to stop and think why. Are there barriers for certain populations in accessing our institution? And then we need to work to address those factors. But then on the flip side, we also need to work on meeting people where they are. So we need direct clinical outreach and partnerships to increase access to specialty care specifically. We know that patients at community health centers typically have barriers and difficulties accessing specialty care. So it's really important to meet patients where they are. I actually just recently started doing 1 full day a month at a community health center. Hopefully I'll be able to increase that as I move forward, just to make it easier for these patients to access specialty care. Many of the patients have really enjoyed it, and they said it's much easier than going to the big institution, because oftentimes patients don't feel comfortable going to the big academic institution. We also need to invest in communities and support minority businesses. If we're doing work at our institution or in our department or division, we need to think about working with minority vendors, putting money back in those communities, and really working to lift up the communities that surround us. And then we need to work on policies. So we need to think about our insurance coverage policies, and then we need we need equity in some of these social determinants. So equity in housing policy, education, and other social determinants of health. And some of you may have already seen this figure before, but this is kind of the phase and the different phases in working towards becoming anti-racist. So there's the fear zone, and at this point, an individual might avoid hard questions. They might deny that racism is a problem. They might strive to be comfortable, and they may only talk to others who look and think like them. Or are they in the learning zone, right? The next phase. So understanding your own privilege and ignoring racism, seeking out questions that make you uncomfortable, recognizing racism as a present and current problem, educating yourself about race and structural racism, being vulnerable about your own biases and knowledge gaps. And I think this is really important because nobody knows everything, but willingness to learn, I think, is what's most important. And then listening to others who think and look differently than you. And the last phase is the growth zone. And so are you speaking out when you see racism in action? Are you sitting in your discomfort? Are you promoting and advocating for policies and leaders that are anti-racist? Are you identifying how you may unknowingly be benefiting from racism? Are you educating your peers about how racism harms our profession, not letting mistakes deter you from being better? We all make mistakes, and I think it's important to be kind to ourselves. Yielding positions of power to those who are otherwise marginalized, and then surrounding yourself with others who think and look differently than you. I think it's important to realize that this is a process. If you're in the fear zone today, after some time you could end up in the growth zone. It's a process. Be kind to yourself. None of us know everything, and I think it's important to not be afraid to be uncomfortable and to really work on getting to this growth zone. So achieving equity in GI, and actually equity in health in general. So achieving health equity. So we need to assure the conditions for optimal health for all groups, especially those who have faced historical disadvantage. When achieving racial equity, we need to name racism and identify its relationship to the social determinants of health. We need to routinely monitor for differential exposures, opportunities, and outcomes. We need to identify structures of racism in societal structures, policies, norms, and values. And we always need to ask in every situation, in our clinical encounters, again, grant review committees, selection committees, in life in general, how is racism operating here? How is it leading to differential opportunities? I think once we start looking at the world with that lens, we can really work towards achieving health equity and equity and liberation. So on the left side, equality means giving everybody the same thing. So here you can see 3 individuals who are trying to watch a baseball game. When we give everybody the same thing, they each have one box to stand on. The individual who is the shortest cannot see over the fence. However, the one who's the tallest can see even better than he could see before. So quality is clearly not the answer when we're thinking about equity in GI and in health in general. So when we think about equity here, equity means giving each individual person what they need to be healthy. That's health equity. Equity in this image means giving the shortest person 2 boxes to see over the fence. The middle person needs 1 box so they can still see, and the tall person doesn't need a box. So everybody can see here at the same level. So each person has what they need to see this baseball game. But really what we need is liberation. And that means tearing down the fence, right? Why did we have a fence in the first place? It means dismantling the systems and structures that have led to inequity in the first place. And that's what we really need to achieve the best health possible for everyone. Thank you. That's it.
Thank you so much. Mel, are you moderating?
Sure, what a wonderful presentation.
Yeah.
Thank you very much.
Thank you.
It was fantastic. I just want to make sure that people actually know that Dr. Kamara Jones is a presidential chair for UCSF this year, and we will have a joint grand rounds with her sometime early in 2022. So we're very pleased that.
That's amazing.
Yeah, we're so pleased with that, and very pleased that you sort of set the tone for that, because I think there's a lot of good synergy there.
Oh, she is an amazing speaker, amazing person to learn from. And I might actually sneak in and watch that as well. I've heard her talk so many times, and each time is even better than the last.
Oh, we welcome you.
Thank you.
There are a couple of talks. If people have a couple of questions, if people have other questions, please feel free to put them in the Q&A. But one was, why is there a lower likelihood of being waitlisted for a liver transplant among Black patients?
That's a great question. So we see that we've seen it in the pediatric population. We've also seen it in the adult GI population. And honestly, the thing that's difficult is that liver transplant is, in some ways, there are objective numbers like the MELD, which, different factors go into MELD, some of the lab results go into MELD, and you can see how clinically how somebody's doing. But there are also some subjective factors. So, there's a transplant meeting where you talk about an individual's social supports and how well they're going to do after transplant. So really bias can creep into that. And that's why I think it's really important when we think about, especially liver transplant, because it is life and death, really that we're looking at our own biases. We're really making sure that we're treating each patient equitably, and we are ensuring that we're being fair, because particularly with liver transplant, it's a matter of life and death. And even though there are objective factors, when you get to that transplant meeting and you're thinking about wait lists, a lot of the factors that we discuss are subjective.
So related to that, in a way, I was curious why you think there are differences in the surgical complications for those who undergo surgery with inflammatory bowel disease. Is it the approach of the physician? Is it because of the care that the patients are getting before they come to the physician, which probably would make sense?
Yeah, that is a great question. And I don't have the exact answer for that. What I would suspect is that some of these patients may be sicker when they're going to surgery. It's been suggested that Black IBD patients, especially Black patients with Crohn's, have more severe disease. They have more penetrating and stricturing disease, which are more severe disease phenotypes. Their surgeries might be more complicated overall. And all of those factors may lead to the different outcomes that we see. But to be 100% honest, I'm not sure of that answer. But we do know that overall, Black patients with IBD also start more anemic, again, suggesting that they might have more severe disease. So that can lead to complications as well.
Although it's complicated also by the observation that if patients have delay in treatment, they may develop more complicated disease. And so are they getting more complicated disease because there's a delay in the treatment for the patient?
Exactly. And that was similar to that first study looking at disparities in workup and the time to colonoscopy. And oftentimes, and I hear this anecdotally, I hear this from patients, I hear this from friends who have particularly Crohn's disease. There's a new organization, it's called the Color of Crohn's and Chronic Illness. It's a patient group for minorities with IBD, but even there, I hear as well that many patients were coming in and out of the emergency room with pain and with, issues, but they took them a long time to be diagnosed. People thought that they were seeking narcotics and, they were this and they were that, but before somebody diagnosed them, it was a year or even more. And oftentimes people really suffered with these diseases. So then when they finally came to diagnosis, they were much more severe and their phenotype was much more severe than it would have been otherwise.
So when I was training, I was at LA County and we took care of a lot of patients with sickle cell disease.
Mm-hmm.
There was a thought that a lot of the patients were coming in complaining of crises because they were seeking drugs. And what I found was if you treated their pain, they stopped using the drugs when the pain resolved.
Exactly.
There's a learning curve there.
Exactly. And I think that the difficult part is pain is subjective, right? So people can't measure how much pain somebody is in. And it's easy to make assumptions, but it's real. And oftentimes we need to look at how we're treating some patients over others, particularly when they're coming in sick and in pain.
So hopefully you won't think this an unfair question being an adult internist.
Okay.
But Richard Quint is one of our senior faculty members, hi Richard, asked whether there have been any studies that look at such disparities in children with developmental or physical disabilities, say for example, GERD, particularly when a child's ability to communicate may be limited.
So that is a wonderful question that I don't know the answer to, but I would assume that yes, especially if there's limited ability to communicate, but also we see disparities in the disabled population as well. They're definitely a vulnerable population that also face disparities. A lot of this talk was based on racial and ethnic disparities, but there are a whole host of disparities that we see in the disabled population as well. And that also lead to poor health outcomes. But the exact answer to that specific question, I don't actually have. I apologize.
Okay. A question from one of our GI fellows. In mentoring high school students to go into healthcare careers, I have found that many cite costs as a reason they choose or against becoming a doctor. What's being done about this barrier?
So I think that is such a great point. So I think a lot of things can be done, right? I think putting money out there for scholarships, particularly scholarships for people to visit, like to do summer programs to get exposure, but really scholarships in terms of, medical school, for undergraduate, et cetera, really helping people overcome the cost barrier. But cost is a huge factor. And we saw in this talk that cost can be a huge barrier for people, but we really need to work on making things more accessible, doing better at providing scholarships for individuals who really need it, and making sure that everybody has an opportunity to do what they want to do and not have cost be a barrier.
I think this is Carol Miller, was asking whether disparities in social determinants of health negatively impact post-surgical care as well.
I would assume yes. So we know that in terms of healthcare in general, it's usually 80% of what determines an individual's health and health outcomes happens outside of a clinical encounter, and that's all the social determinants of health. And only about 20% of the clinical care impact that. So I would say yes, it's 100%. 100% sure, 100% likely that those social determinants are impacting those poor surgical outcomes as well. In GI, but also in other areas and other fields as well.
So you mentioned some of the challenges that are being faced by faculty. And I was curious if you have any thoughts about the minority tax supposedly that's occurring.
Yes.
Given that the underrepresented minority faculty members tend to be asked to participate in more committees and interview
Oh my goodness.
more
Yes.
represented minority
Yes.
applicants and so on.
Yeah, so I am also a victim of the minority tax. I think it's really challenging because oftentimes, divisions and departments, especially in academic medicine, we know that there's a lack of diversity. So then it's the same people who are asked to do diversity work and are pulled in so many different directions. And these are often, like I said, things that are not in positions that are not promotable. So I think there's a few things that can be done. And one thing that Harvard did was actually start to include DEI as one of the factors for promotion. So there's like 3 different tracks, but then there's other supplemental things that you can do on top of that. So DEI work now is added recently as one of those supplemental factors that can really push someone forward towards promotion. I also think it's really important for mentors to understand the minority tax. I'm really happy that you asked that question, so they can really help guide their mentees in, work that is valued or valuable to them in their career and work that will be less valuable to them. So, if they come to a mentor with a question about whether or not they should act on this committee or that committee, really telling them like, no, I don't think that this is gonna be helpful for your career at this time. And maybe next year, maybe in 2 years, but now might not be the right time. So I think really being a great mentor and then also reevaluating the promotions process can be helpful with that. But the minority tax is really a challenge, and learning how to say no is another thing I think is really important, is a skill that nobody teaches us, and especially as a junior faculty can be really challenging, but I think it's important to be discerning and really realize that no, somebody said this to me before, and you've probably heard it in the past, and I have been really trying to embrace it, but that no is a complete sentence, and really using that sentence when it's necessary.
Sandrine?
It's funny that you say that. I actually have a couple of slides that I share with groups of junior faculty often that says saying no so it sounds like yes. And what it mostly actually means is saying no in a way that it keeps doors open and actually works to your benefit rather than your detriment. Because I think that that's the skill that people need to learn.
Exactly.
I have a question about mentorship though, and it relates to this minority tax. You were saying that it would be important to mentor people that don't look like you. And this, of course, is something that we are really, we don't really have good answers to. We have now close to 50% of our pediatric residents are from groups traditionally underrepresented in medicine.
That's great.
And that's
awesome.
That's not reflected in our faculty yet. We're working on it, but we're not there. And there's this tension there because some people feel strongly that UIM trainees should be mentored by UIM faculty, but I heard you say that maybe that actually isn't necessarily always the best route. So can you give your thoughts on the pros and cons there with these mentorship relationships?
Absolutely. And I can speak from personal experience as well. So I have been really fortunate to have some really great mentors. So even right now, I would say my mentors are mixed. So nobody should have one mentor. You should have a whole host of different mentors that you go to for different things. Many actually of my mentors now are Black women, some in GI, some out of GI. But some of my mentors are white men throughout my career. Some of my mentors are white women. Some of my mentors are from other backgrounds as well. So I think it's really important to have a mix. And I think it's important for people not to mentor people who look like them, because sometimes there's different things that different mentors can provide to a mentee, right? So as a mentee, it's important to have a lot of different mentors. Some maybe that look like you, but some that don't as well. And each mentor can be used for different things. So I have some that I go to for life advice, some that I go to for work-life balance, some that I go to for research advice. some that I go to help me say no. And it's really important to have those different mentors, but that they're also diverse as well. I would say my mentors are diverse, and I feel like I've been very fortunate in that, but I think we should all have diverse mentors and mentees, and know that not one mentor as a trainee. It's important to know that not one mentor should be the end all be all. You need a team of mentors and different people you go to for different things. But I do think it's important for minority faculty to have access to minority junior faculty and minority trainees to have access to mentors who do look like them. I think it's really important. And I've been fortunate in that. And for the trainees who are here, I would say, don't be shy about looking for mentors, especially if you can't find them immediately at your institution. I've gone up to conferences and I've spoken with people who I'm still in touch with today, who have opened doors for me and have led me to where I am today. My first mentor, I met actually in the parking garage and I said, hey, I heard you were coming here. I would really like to meet with you and chat more. We still keep in touch today. I've known her for over 10 years. So it's really important just not to be shy, to go up to anybody that you think that you can learn from and gain from, and even to email people that you're interested in knowing. I think there's really, if you can't find your mentor at your institution, they're in there, they're out here somewhere, and you just have to find them. And if you see them, stop them.
Dr. Ethnicity, thank you so much. Wonderful talk. And I'm going to leave the last word to Dr. Hirsch.
Well, I want to also thank you, Dr. Ethnicity, for joining us today and for giving us such a wonderful grand rounds. And I want to thank everybody for participating and wish you a good rest of your day.
Thank you so much for having me.